Let's move to the next speak. It's targeting for the CDK 6 and 4. The speak is Nicholas Turner from UK.
So thank you very much. I'm very grateful for the organizers inviting me to come and talk about the use of CDK4/6 inhibitors in early breast cancer. So just here are my disclosures. So the background to this talk is, of course, the increasing understanding we have about the importance of cyclin D1 and CDK4/6 in the biology of ER-positive breast cancer. So we now know very clearly that the growth of estrogen receptor-positive breast cancer is dependent on cyclin D1, which of course is the cognate cyclin that activates cyclin-dependent kinases 4 and 6 to initiate the cell cycle. There are multiple activators of cyclin D1 in breast cancer. Cyclin D1 is amplified in about 30% of ER-positive, HER2-negative breast cancers. Cyclin D1 is also one of the key genes that the estrogen receptor itself induces, and is also a target of mitogenic signaling, MAP kinase and PI3 kinase signaling. Cyclin D1 itself also binds the estrogen receptor, and independent of its role in activating CDK4/6, promotes ER's transcriptional activity. And this is probably one of the reasons that the estrogen receptor-positive breast cancers become so dependent on cyclin D1 and ultimately CDK4/6. And of course, CDK4/6 phosphorylates the retinoblastoma gene to initiate the cell cycle by partially activating the E2F transcription factors. We, of course, now seen multiple phase 3 studies that have demonstrated in the metastatic setting substantial benefit, leading to these, of course, becoming if not the standard of care for treatments with metastatic ER-positive breast cancer. Here are the 3 studies with CDK4/6 inhibitors given in combination with aromatase inhibitors. And on the next slide, the 2 studies that have given CDK4/6 inhibitors in combination with fulvestrant, all showing an approximate doubling in progression-free survival by adding on CDK4/6 inhibitors. And we're also now beginning to see some evidence of the impact of CDK4/6 inhibitors on overall survival, PALLET that we presented last year, with likely further overall survival data to emerge from the studies this year. So let's move now and talk about activity of CDK4/6 inhibitors in early breast cancer and go through the studies that have looked at CDK4/6 inhibitors, just needing to emphasize that all of the data I'm going to show you is using surrogates of proliferation Ki67. So it's evidence of activity, no real evidence yet of efficacy, improving outcomes for women with early breast cancer. First of all, what about CDK4/6 inhibitors alone? So we have the POP trial, and so this was a window trial of giving patients with breast cancer 2 weeks of either palbociclib alone or no treatment preoperatively in 100 patients, the vast majority ER-positive. On the left, showing a really substantial Ki67 reduction response with palbociclib, very little in control, and also confirming that we can see evidence of on-target effect of palbociclib alone through loss of RB1 phosphorylation. We then have single-arm studies that have also looked at CDK4/6 inhibitors in combination with endocrine therapy. So this is the NeoPalAna study presented by Cynthia Ma and colleagues, which was a single-arm neoadjuvant study, which had a run-in of AI alone, followed by palbociclib and AI with a biopsy after 2 weeks of that combination. And then top right here, we see the results split out by luminal A or luminal B. And we see in the middle, at cycle 1, day 1 here, we've got what the proliferation looked like just after the AI alone run-in. And at the end here, we've got the proliferation after adding in the CDK4/6 inhibitor. And what this study seems to be telling us is that there are some tumors that have still significant proliferation after their aromatase inhibitor. But when you add in CDK4/6 inhibitor, the substantial majority of them substantially reduce their proliferation. So CDK4/6 inhibitors potentially are active in AI-resistant cancers. But this study then gave the combination to the point of surgery, but importantly, the investigators were worried about neutropenia and surgery, so they left here a gap between the stopping of palbociclib and surgery. And down here is what happened to proliferation in the tumor if you look at what happened in surgery with that gap after stopping CDK4/6 inhibitor. And we saw a big rebound in proliferation in the tumors after stopping palbociclib. And clearly this is telling us after this duration of treatment, the effects of CDK4/6 inhibition are potentially reversible, potentially telling us something about duration of therapy, which we'll come back to a little bit later in the talk. But what about randomized studies? So we've seen 2 neoadjuvant studies that have randomized patients between different endocrine-based options. The first of these to report was the NeoMonarch study that randomized about 200 patients between anastrozole and abemaciclib, or abemaciclib for 2 weeks, again then with another biopsy to reassess Ki67. And then all patients went on to receive the combination. So from this study, we can look at the 2-week biopsies. In those, we see the Ki67 change with anastrozole on the left, and then in the middle, we have anastrozole and abemaciclib, and we can see really quite substantial suppression of Ki67 in the really substantial majority of patients treated with anastrozole and abemaciclib, showing activity of CDK4/6 inhibitors in the majority of treatment-naive ER-positive breast cancers. And then also looking at gene expression in this 2-week biopsy. In gray is expression of anastrozole alone, and then the colored are those on the CDK4/6 inhibitors, and these are classic cell cycle E2F target genes showing substantial potent cell cycle shutdown and loss of E2F transcription by adding on a CDK4/6 inhibitor. And then the final study I'm going to show you of the neoadjuvant studies are the PALLET trial, recently reported by my colleagues from the Royal Marsden, Steve Johnston and Mitch Dowsett, where they took 300, again, treatment-naive, ER-positive, HER2-negative breast cancers. For 2 weeks, they were randomized between letrozole and various combinations of letrozole and palbociclib. And then importantly, after that 2 weeks, one of the groups continued on letrozole alone. So we now have some longer-term data of 3 months of being able to compare letrozole with letrozole palbo. So then we can have a look at the results of the study. So at 2 weeks, we have the combination of patients who are on letrozole for 2 weeks, letrozole, again, letrozole for 2 weeks at the top right, palbo for 2 weeks at the bottom left, and the combination of letrozole and palbo. And at 2 weeks, what we can see here is it's the combination that really shut down proliferation at 2 weeks. But then this group here continued on letrozole alone for 2 weeks, whereas all the other groups switched to letrozole and palbociclib. And you can see at that 14-week point, there's really substantially more suppression of the tumor out after 3 months of treatment with letrozole palbo, again brought out on the right here, showing complete cell cycle arrest in 90% of the patients with palbociclib and letrozole, compared to 60% of those who are treated with letrozole alone. So we've got quite a lot of evidence now that in these relatively short preoperative studies, we've got evidence that CDK4/6 inhibitors are also active in early breast cancer. And what about the adjuvant trials? So there are a number of adjuvant trials that have completed recruitment already. The first of these that is most likely to report before the others was a study led by the GBG of a post-neoadjuvant study. So these were ER-positive, HER2-negative breast cancers who had not had a pathological complete response to neoadjuvant chemotherapy. They were at high risk on a clinical staging score, and then they were randomized between 1 year of palbociclib or placebo, obviously given with endocrine therapy. The other large adjuvant study with palbociclib is PALLET. So this has recruited 5,600 patients, both higher clinical stage, as well as a cohort of really relatively low-risk patients with stage 2A. And these patients were randomized this time between 2 years of palbociclib with endocrine therapy or endocrine therapy alone. And then the third study that's recruited is the Monarchy study, which is a very similar design to PALLET with adjuvant abemaciclib, but relatively restricted to higher risk patients, node positive and with other high risk features such as multiple lymph nodes, high tumor grade or high Ki67, randomized to endocrine therapy or 2 years of abemaciclib. And then we have, finally, the last of the adjuvant studies I'm going to mention, which is NATALY, which is just starting up now, which is the phase 3 study with ribociclib, again in stage 2 and 3 ER-positive breast cancer, this time randomizing to 3 years of ribociclib in combination with aromatase inhibitors or aromatase inhibitors alone. So what can we expect from these adjuvant studies? And of course, this is speculation on this slide. I think it is likely that CDK4/6 inhibitors will have an early relapse in the first few years, in particular when patients are on the CDK4/6 inhibitors. And I think we can have some confidence of this because all of the studies in the metastatic setting show early curve separation through blocking early progression on endocrine therapy. And I've shown you here on PALOMA-3. But of course, we remind ourselves that early relapse in the first few years is really not the main problem in ER-positive breast cancer, where the rates of relapse in the early years is relatively low compared to the continuous ongoing risk that there is potentially up to 20 years. And clearly, longer follow-up is going to be critical on all of these studies to work out what impact CDK4/6 inhibitors have on this potentially much more substantial risk of later relapse. And then, what's the optimal duration of therapy? Now, of course, we have to be careful with cross-study comparisons, but we have now a number of studies that are giving CDK4/6 inhibitors for different durations. And this might start to give us some hint about ultimately whether we're going to need to address the question of duration of adjuvant CDK4/6 inhibitors, as we have one study giving CDK4/6 for a year, but in a very specific population after neoadjuvant chemotherapy. And then we have in the adjuvant setting 2 studies that have given 2 years of CDK4/6 and 1 that's going to give 3. And this, of course, may give some sense about whether longer duration of CDK4/6 inhibitors is important. But what about biomarkers? Of course, what we really are going to want to know is which tumors actually require CDK4/6 inhibitors. Now, of course, prognostication is one aspect of it, but what I'm going to talk about in the last part of my talk is the recent evidence trying to pick out predictive biomarkers, identifying tumors that might be resistant to CDK4/6 inhibitors. We know, or at least we think, they're out there to be found in early breast cancer. I'm coming back to the NeoMonarch data here, and in the middle is looking at Ki67 on AI and abemaciclib, and there appears to be a small group of cancers that are not showing any drop in their Ki67, showing some evidence of primary resistance to anastrozole abemaciclib. Now, we don't know who these are with confidence in early breast cancers, but we're beginning to learn something from metastatic breast cancer. So here's a series of patients, of 350 patients, all treated with CDK4/6 inhibitors as part of their standard of care, and looking at prognosis on their CDK4/6 inhibitor. So it's a little bit difficult here to be absolutely certain about whether we're looking at prognostic or predictive factors, as this is standard of care use, not from a randomized study. But nevertheless, in this series, they could pick out mutations in 2 genes that appeared to associate with particularly poor outcome. So one of those was mutations in the retinoblastoma gene itself. You'll all recall this is one of the key targets of CDK4/6. And in about 2.5% of patients with advanced ER-positive breast cancers, there were RB1 mutations that led to true loss, and these patients appeared to do very poorly on treatment with their CDK4/6 inhibitors. And there's also further evidence to support RB1 mutations that has come from looking at circulating tumor DNA at the end of study in PALOMA-3, looking at those mutations found in circulating tumor DNA, where I've boxed out here, we see acquired retinoblastoma mutations only in those patients treated with palbociclib, presenting further evidence that these are genuine resistance-causing mutations when they truncate and inactivate RB1. Back to the same study I was showing you before, also now looking at another gene called FAT1. And those tumors in blue here that had true inactivating mutations in FAT1 again seemed to progress very early in the metastatic setting on CDK4/6 inhibitors. But these are really pretty rare. Black and blue here are the inactivating mutations, perhaps present in about 2% of metastatic breast cancer, but less than 1% of primary breast cancer. And there's some biological understanding of what these mutations might do. FAT1 mutations appear to activate Hippo signaling, which leads to overexpression of CDK6 that I show you here in the data here, which is from Sarat Chandalapati's lab. But why CDK6 overexpression causes resistance is the really interesting question that comes from this work. But then the final piece of data we have, potentially looking at predictive biomarkers, has come from gene expression analysis in PALOMA-3 and looking at the cyclin E1 gene. And so if we look at those tumors on the left that have low cyclin E1 expression, they appear to get very substantial benefit of adding in palbociclib to fulvestrant, whereas those patients on the right that have high cyclin E1 expression appear to derive less benefit from adding in palbociclib with a highly significant interaction p-value. And this finding was more significant in those when measured in advanced disease biopsies than in the archival primary. What's going on here? Well, cyclin E1 is one of the genes that is stimulated by the E2F transcription factors, and also in PALOMA-3 you can also find that signatures of high E2F activation associate with relative resistance to palbociclib. And what E2F and then leads to overexpression of cyclin E1, and this activates CDK2, which is one of the key bypass kinases for CDK4/6. So cancers with high expression expression of cyclin E1, have activity of CDK2, and CDK4/6 inhibitors are unable to work any longer. And this pathway, potentially, you're getting lots of convergence here, that multiple potential mechanisms of resistance ultimately all feed in to promoting E2F activation or cyclin E1 expression. And for this potential biomarker, we have got some evidence that it might be relevant in early breast cancer as well. So on the left here, we're looking at cyclin E1 in early breast cancers in the POP trial. This was 2 weeks of palbociclib alone. And so those tumors that had high cyclin E1 expression had a much lower rate of Ki67 suppression on their CDK4/6 inhibitor. And then on the right here, we have the NeoPalAna study, again looking at CDK4/6 inhibitor palbociclib. The data is here shown in a slightly different way, but in blue are those tumors that were marked as being resistant to CDK4/6 inhibitor. And then in baseline, these tumors again look like they may have high cyclin E1 expression. So, let's just conclude. So that CDK4/6 inhibitors appear to have high activity in preoperative and neoadjuvant studies. Adjuvant studies have recruited, and we're waiting for the events for these to be reported. We do have emerging clinical biomarkers. We have really very rare mutations in RB1 and FAT1 that may identify resistance to CDK4/6 inhibitors. We've identified that overexpression of cyclin E1 may associate with relative resistance, but none of these, of course, yet are ready for clinical implementation, requiring substantially more work. Thank you.
Okay, thank you. Any question from the audience? Yes, please.
The information on the CDK6 high expressors is interesting. When you send off your patient's tumor for genomics, often you get back amplification of CDK4 or CDK6. Is there any information on those being, and if you look to the column to the right on the report that you get back from the genomics company, it says, use these drugs, so to speak. Any information on that?
Yeah, so there's two answers, I think, to the question, Kent. The first one is just the clinical, practical association, which was we are definitely not ready to influence use of CDK4/6 inhibitors on the finding of CDK4 or 6 amplification. There's really no data. The much more interesting translational question is, I showed you one piece of data, but there's a number of other pieces of data that suggest that overexpression of CDK6 may be a mechanism of resistance to the current generation of CDK4/6 inhibitors. And the question is, why? It can't really just be about overexpressing CDK4/6. Potentially there's complexes of CDK6 that the current generation of inhibitors inhibit poorly. And I think we're going to see really interesting data coming out in the next year or two, trying to understand what is this association between CDK6 and resistance.
Okay, thank you. Any question? Okay, I have a question. We have lots of clinical trials for the hormone receptor positive patient. So what's your comments for the CDK4/6 inhibitor in HER2 positive patient or triple negative?
Sure. So, I was only talking obviously about ER positive in this. Preclinically, there's substantial evidence that HER2 positive breast cancer models are sensitive to CDK4/6 inhibitors. In fact, the very earliest data came out in models of HER2 amplification-driven breast cancer. So I think there's a lot of preclinical evidence that CDK4/6 inhibitors could be active in HER2-positive breast cancer, and in the metastatic setting, there's a number of trials that are either ongoing and some that actually have recruited, called Monarch-HER, which are going to provide some data. Generally in triple negative, most basal-like are intrinsically resistant because they have high levels of expression of cyclin E1, but potentially there are some data that the luminal triple negatives might show some activity of CDK4/6 inhibitors.
Okay, thank you.